Lynn, when BJ gave her presentation, and I just happened to think of this with Hurricane Katrina, and this might pertain to what your field as well.
Hmm.
Um, if one is getting all these individuals in the football stadiums or basketball courts
Hmm.
for housing, temporary housing, I'm just thinking about the logistic nightmares, the logistic challenges of getting wheelchairs, medications to those who need them critically.
It's an absolute nightmare, absolute nightmare. And I'm going to be addressing the medication issue. Uh, it, I'm going to bring in disaster preparedness when I talk about this because there's a tool I have on my website that I have used for over 40 years, different renditions of it. And it helps. But I'll also try to integrate what I'm talking about, medication related problems, also with the disaster preparedness, because we just need to do something in order to be prepared in case of emergency. We also need to be prepared to prevent falls, and they kind of go along together. We just need to tie it all together.
Mm-hmm. I think we're getting there slowly in a lot of cases, but I think we are making a good effort to serve the population we do, and I can see residue effects as well.
Well, the biggest challenge that I see in having I have seen in healthcare is getting people to listen.
Hmm.
And sometimes it's the patient, sometimes it's the caregiver, but we need to be engaged, and we can't think, or we can't be non-believing. We've got to at least think about things. And when we have those emergencies, we're not thinking, we're just acting.
Hmm.
And uh, we need to have a dress rehearsal. And I do. I have my whistle and everything. And I have my bags packed, ready to go out the door. And the other thing is, um, I also use that when I travel by car. I have my emergency supply with me and I take it with me.
Hmm.
And for some patients that are on really unusual medicines, and they need to be even more involved in their planning. And so we've had a lot of things happen in this state. In the 70s, when I was on site, I had a pharmacy inside a large nursing home. The National Guard came and got me, picked me up, and brought me into work. And I lived at the nursing facility in order to be able to provide the medicine because the roads were so impassable. And we don't think about how hard it is for all the healthcare workers to get out and do their jobs. We just expect them to be there, but we can help them and respect them more by being prepared ourselves and not be an additional emergency.
Hmm. And I think we sometimes forget that medical people, first responders are people. They're human beings.
Absolutely. Absolutely. And one of the things in our country compared to a lot of other countries is we have a belief that everything's going to be there all the time when we want it, how we want it, and all we have to do is go out or make a phone call or whatever, and it's there. And the disasters kind of bring us to reality.
Hmm. I agree.
When does this supposed to start? At 11?
Yes, ma'am.
Okay.
A break, early morning break, is a good thing at times. So,
Well, there's a lot of things you have to take care of when you first get to your office,
hmm.
and the break is nice to make sure things don't bubble over into the afternoon.
And you never know what's going to surface.
Oh, no. And that's one of my issues about signing up to attend a class. I have all the good intentions of making the class, but you never know how things are going to change from one day to another.
Mm-hmm.
So, one of the things that I did during COVID, trying to make sure my little neighborhood area was safe, we went with I gave everybody two pieces of paper. One was red and one was green. And if everything was okay with them, they would put the green one in their window. And if they needed help with something, they would put the red one in their window. But I also asked them to change the placement every day so I know they were actively updating their status. And, basically the reason I did that was because I could walk by and look at all the houses in very short order rather than make all the phone calls. And it was nice. We kind of kept that, you know, close to us as to what we were doing, and it worked. And have you heard of people using telephone trees?
Yes.
Sometimes that works, or it lets everybody know that
Mm-hmm.
they're okay or
Yeah.
something's
Recall.
needed.
We called them recall rosters,
Okay,
and
that's a good name too.
it works well when people actually follow the limbs, the tree pattern. You don't call this person way over there. You call
Mhm.
who you're supposed to.
That's right. Well, that goes back to us all, being what we call freelance. We need to know what our plan is and we need to work our plan
Mm-hmm.
and be
Okay.
a little bit more organized. It's hard.
Yes, ma'am. Are you ready?
Well, I guess so. So I just need to turn on my share button. Let me
And
see.
you're in speaker mode.
Yeah, let's see. Do. I want to, let me see. Let me get, I have, hmm, it tells me I need to sign on to Zoom.
Okay. You may have to sign in. Did you sign in earlier?
Yeah.
Okay. Hmm. May have to backtrack. It may just be one of those technology gremlin things. But you go down to hit well, on my screen, it's share is a green button with an arrow.
Yeah, I've got, okay. That's the one I was hitting. And there it is.
Okay.
Well, I'm trying to get it where it's full. Can you
It's
read that?
kicking in. Yes, it's kicking in. There it is.
Okay, but what I was trying to do, yeah, there it is. Okay.
Okay. Okay. And as a reminder to everybody, please mute your microphones. And we got a wonderful presentation coming right up.
Are we ready to start?
Yes, ma'am.
Okay. My name is Lynn Harrelson. I am a pharmacist that has practiced in the senior market for almost my entire career of 40 years plus. And I am very, very concerned about uh, the role that medications have for the poor outcomes for our patients, particularly in fall prevention. So, I wanted to talk about medication related problems. And many people think that medication related problems are dispensing mistakes. They are not. Um, what medication related problems are, and there are something that we definitely need to prevent, is the medication related problems are one of the biggest reasons that our patients lose their independence, they lose their health, and we lose them. So I'm going to see if this works. Yes, it does. Medication related problems, people don't understand. They think it's just the drug. Some people think it's the way the patient takes the medicine. It may be, but more importantly, it's how the individual responds to the medicine the way they take it over a period of time. It's uh, the individuals who have had opportunities taking care of an older patient knows that there's lots of complications in aging, uh, just to be able to live through the day. But those are the kinds of complication that can cause medication-related falls, and those complications are tough in and of themselves. But when you add medications to the mixture for a patient, it's even more problematic. As I said, medications are many times the problems, but those problems build on the medications. While we think that our prescriptions are going to make us better, sometimes it doesn't happen. We just have problems or challenges. I call them operational issues, secondary to the medicines we use or how we use them. These are factors and falls that we are concerned about. Falls in and of themselves, independent of medicine, can be caused by changes in our sight, how well we are able to move not only our feet, but to use our hands for the grab bars, the physical changes, whether we have the stamina to walk across a room, down a hallway, whatever. We have falls because we make bad judgments about what we're trying to do and how we're trying to do it. We have falls because we forget what we're doing, or we get confused in how we progress through the day. Pardon me. The memory problems are also an issue. Some people get anxious about just things, and they become agitated and anxious and get into a simulation type thing, and they just become very, very excited. And as my grandmother would say, you can't get one foot in front of the other. And that's sometimes what happens. Um, People also fall because they have depression or the delirium that may come with other conditions, and it causes individuals not to be focusing on what we do. What's ironic is medications, if we understand our medications, we'll appreciate that medicines also can worsen the visual problems. Just being able to stay awake, to not have anxious feelings, different side effects from medicine can cause a lot more problems, and potentially medication-related problems and falls. And so why is that? So much of a problem for today's seniors in particular. It's for other people too, but for seniors, is our system is rather disjointed, and there's a whole lot of experiences with different healthcare providers, and we see a lot of different healthcare providers. Many seniors see a doctor for every specialty type disease or complication they have. The medicines are ordered through multiple prescribers. Medicines are obtained from many or different sources. We have community pharmacies, we have hospital pharmacies, clinic pharmacies, ambulatory care pharmacies. They're in the community, they're in the doctor's office buildings. Some physicians have samples. We're seeing less and less of that, but sometimes that can be an issue. The long-term care, home health individual businesses offer prescriptions to patients. We have compounding pharmacies for special things that patients may need, or they're allergic to an item in a regular medication, and so it's compounded. But what's happening is all those pharmacies have different data bank information about what the patient is taking. And this is the problem that I have seen over my lifetime. Let me go back and just tell people what I do. I provided the medication management care that was required under Medicare when Medicare was enacted shortly after the enactment, there was a requirement for pharmacists to do the medication reviews, and that's what I did in the nursing homes and did it for most of my life. And we would see all kinds of problems with patients who were being admitted uh, from the homes or from the hospitals, and there were a myriad of problems. But the biggest problem that I see today, it was a problem then, but it's much more now, or the number of different pharmacies that are utilized. The more sophisticated medicine is more chemically complex. The prescribers generally know some of their medications that they prescribe fairly well, but they don't know what other specialties might prescribe, and they don't know how the interaction happens. And that's what the pharmacist does check. And we do check the interactions, but we get interaction reports that are moderate or more significant. But our senior patients may have interactions that are deemed to be minor, and in reality for that senior they're a major. But we have so many different pharmacies, and the information of all the medicines that is being taken isn't always provided to all of the pharmacists that are filling prescriptions. The electronic medical record that was introduced has helped a whole lot, but still, they're not on the same platform, and they still do not use the same database of information as to the drugs that are being utilized. The doctors, healthcare providers, prescribers see a patient, and they have an intervention and a doctor's appointment, and they do an intake as, are you still taking this medicine? Are you still taking, they go through the list, and that post-appointment list is shared with the patient. But that post-appointment listing of the medicines used should have the over-the-counter items on it, the non-prescription items, but we do not have, the pharmacies do not get that information. A lot of people kind of poo-poo or discount the medicine. They do not think that the medicines can be a problem for patients. Healthcare providers are one of the biggest ones I've seen. Well, that can't do that. That can't happen. They don't appreciate it until it happens in their group of experiences. That's why I think sometimes older practitioners who've seen a lot more patients with a lot more problems are sometimes more open to this, but we all learn, we all see things. The public at large do not believe that medications are a problem, and that is because we want to believe that what we're doing in regards to our healthcare is for our own best interest. Seniors and their families also want to believe, it's kind of a placebo effect. We want to believe that that medication is going to be good for us, and we do not believe that the problem is that we're experiencing is due to the medicines that we're taking or how we're responding to it. No risk factor for falls is as preventable as appropriate medication use. If we use the medicines correctly, we can minimize or prevent a large number of falls. It's very, very significant. This is how I see my patients. I've had patients that have come to me taking or you having use of 30, 34 medicines. They're not all like that, but a lot of them are. The word polypharmacy, a lot of individuals are aware of that. And polypharmacy is taking 5 or more medicines, and that is very significant in the state of Kentucky. I'll go into that a little bit more. And that, when people think of 5 or more medicines, what they think of is 5 or more prescription medications. But it's clearly a lot more than just prescription medications. It's the non-prescriptions, and non-prescriptions many times are just as important as prescription medicines because 5 years, 10 years, 20 years ago, those non-prescription medicines were prescriptions and they required pharmacists to provide information and counseling to patients. Over the counters are um, same as non-prescriptions, but they're more long-term uh, use. They usually call over-the-counter medications that were readily available prior to the 70s. But we also have the alternative therapies, herbals, that people who believe in a more natural way, they will use these. And just like certain foods interact with certain foods and the herbals will interact with medicines as well. We have samples, as I mentioned earlier, the that is going wayside where they're giving cards to patients or uh, certain access documents, and it's going through the pharmacy, and the pharmacy is making that available to them in some incidences, and that integrates a check. But when I mention samples, one of the biggest cautions that I have a problem with is I am aware of seniors sampling other seniors' medicines, and it's this works for me. Why don't you try it? And what's happening is a patient's taking a medicine that's never been checked for interactions, not only for falls, but other interactions, allergies, and such. The supplements or the nutritional, the liquids, that type of thing, and that can um, also interact with the medicines. And it also should be a part of the medication list that is used. The previous presenter talked about emergency preparedness. And on my website, Senior Pharmacy Solutions, I have a document that's called ICE, in case of emergency. And what I do is I have a listing of those medicine. I have a place where the patients can list those medicines along with other information. And what I ask my patients to do is to list that all the medicines they're taking and take that listing with them to the doctor. My other caveat to make sure that listing is complete is that they are to, in preparing for emergencies, they are to put all the medicines that they're putting on their list in a bag, a central location area. It can be a box, but I like a bag. And they cannot take anything that's not in that bag or box unless it's on the list. If they have to go to the bathroom cabinet, the hall closet, or wherever they might have a medication stored, they need to make sure they pull it out of that environment and put it on the list and put it in the bag. And then they take that list to their healthcare provider. They go through the list, update the list at the doctor's office, but they also need to provide that listing to the pharmacist. So the pharmacist will know of things that might interact. The polypharmacy issues, medication related problem, it could be a possible interaction. Usually, what we see as pharmacists, we see either major interactions, but for an older person, what might be deemed on the computer may be a major, it may be a minor interaction, but for a senior, it may be a minor, it may be seen as minor on the pharmacist reviews, but for the patient, it may be a major. We have multiple side effects. We call it a side effect load. And what happens, and this is where polypharmacy kicks in, we have more medications to treat the side effects. And then what we have, the pharmaceutical cascade, a snowball of medicine. What happens is we have a side effect early after we get our medicine, and we feel odd or different. We don't feel optimal, but it keeps over the months, it keeps getting a little bit worse, a little bit worse. We as patients don't report that to our healthcare provider. Well, I had this when I first started taking the medicine and it's only gotten worse. We forget about it or discount it. We go in and see our healthcare provider, and all of a sudden it's seen as a new medical condition or a new disease for which new medicine is treated. So when we talk about the side effect load, I've got a prompt that I want to show, and I hope this still works. This is what I show when I give my classes to my patients. These are little medicine cups. Can it be seen? I hope so. These are medication
Yes.
cups, and each one of them represents a medicine. And what I tell my patients is if you see the color red or reddish in these cups, that means there is a severe problem with drowsiness, sleepiness, confusion, or whatever. And the more red, the higher the side effect is. But even if you have a little bit of red, like in the orange, just a little bit, that may be less. But if these, and I just need you to imagine this, if each of these had a shot of whiskey in them and you took those over the day, do you think that we would be drunk at the end of the day? Everybody understands taking too many medications with the same side effect as a problem when they see my little jigger board here. It's a very significant problem. You keep taking a little bit of medicine, you keep adding into that side effect, and pretty soon you have a monumental program. And that's what we need to prevent, but we need patients to speak up. I assume that that's going to be a problem because I know the medicines really well. And some days they may have a even higher side effect with these problem medicines because of things that they do during the day, or not drink enough water, or other issues, or get another medication. But what causes problems in general to be problematic with today's seniors are how our bodies changes with aging, and that's both mental and it's physical. I've seen a lot of medication related problems causing falls because our seniors forget that they've taken their medicines. Um, I've seen them have problems with uh, falls because of how their body is beginning to slow down in their liver function and in how their kidneys function. If that is the way that a medication is eliminated from the body, either through the liver or through the kidneys, when they are not as highly functional, the medication builds up. The dosage levels that are recommended during the drug studies and the research are based on appropriately functioning liver and kidneys and other aspects as well. But when we can't get rid of things, it's just like our garbage cans fill up if we're not able to empty them on a weekly basis or whatever. So that is a problem. It's a natural progression of aging, and we just should be aware that that's going to happen. The other thing that affects how seniors respond to medicine is how we change over time according to how our body is built. And that is the changes in the lean and the fat distribution that we have within our body. Some medications are attracted and bound to muscle tissue and others into fat, and it affects how fast that a medication starts to act or how long it acts after you stop taking it. And it's individually for different medicines in different ways. But all of that changes. So we should never assume that because a patient started on something when they were in their 40s, their 50s, or the 60s at a certain dose, that dose stays the same for them in their 60s, 70s, and 80s. It's not going to usually. We need to be very cognizant. If a patient loses a lot of weight or gains a lot of weight, their medications may act differently. As I said here on the slide, the normal or usual customary dose of medication may be an overdose in many, many seniors. So I have a recommendation that I make for patients is for them to talk to their healthcare providers about is to go slow and how they introduce medicines, but also to go low. It doesn't hurt to have to increase the medicine dose, but let's start slow to make sure we know how we respond and adjust accordingly upward. As we said here, the body's inability to eliminate the prescribed dose far worsens the problem with polypharmacy. Sometimes you don't know which drug's causing which problem because there's so many of them, and they're maybe used in a haphazard way. But even if they're used in a consistent way in a hospital or a nursing home, we still find problems with a patient who maybe used the medicines for years that we need to step down the medicines. We call it deprescribing. I call it a gradual dose reduction. I ask for a dose to be reduced, and we look at that reduction over time, and we make a judgment of whether that reduction was good or not. And the whole request has a whole group of actionable items on it. When we have problems with our medicines and we see all of the confusion and the falls and the attitude, just different things happening with the patient, we think it's aging. And many times what we have is not aging. The problem that we have is the effect or the buildup of the medications that cannot be routinely eliminated from the body. Pardon me. When we do the reviews, anybody, anywhere, we need to make sure that includes all the medications as listed, the prescription, non-prescription, the supplement. We also need to know how they use it, if indeed they do use it, and how that we need to ask them, tell me how you're feeling. One of the biggest challenges that we have in healthcare is we have a rush to provide care. I call it a speed date. And part of it is because we have so many patients, and we have so many patients because we don't slow down and help them take care of themselves and take their medicine in the best way that's optimal for them. I like to say if you've seen one patient using a medicine, you've seen that one patient using that medicine that way. It's very, very important that we give not only the patients, but the caregivers the time to be able to understand how to use the different medicines. If a patient falls, they're going to fall again in 6 months. But many times a patient's having problems immediately after that initial fall. So there should be some kind of checkup by different members of the healthcare team during that ensuing 6-month period before the next follow-up. Anytime we have a plan for fall prevention, we need to include everybody. And the senior is the most important person that we need to include. And I mention this because seniors do not want to speak up about falls. They will not tell you that they've had a fall. The previous presenter talked about the necklace that you can wear if you have an emergency or whatever, if you have a fall. I think that's great because they don't have to report it, but it kind of keeps a record of what's going on and the realities of a fall or a near fall. If we don't know something's happening or something is having more and more of the potential of happening, we aren't going to be able to address it. That being said, I'm assuming all my patients are falling or have the potential for fall when I look at their medicines. We also need to make sure that all healthcare providers know that a patient has the potential for falls. I ask my patients, irrespective of their disease state, to share with their dispensing pharmacy that they have have a tendency to fall or have fallen, just so they might be alerted to more information at the time of dispensing. The family members need to know about the fall prevention, the fall potential with the medicines. And that's one of the biggest challenges I see today versus even 10 or 15 years ago. We don't have as many family members living in the same communities as our seniors, and that creates a problem. Um, we do have caregivers, and those caregivers should also know that there's a fall potential. But the problem that we have with caregivers is they rotate through. We don't always have uh, uh, consistent caregivers day to day. On that ICE list, that potential to fall is one of the issues that I have as part of a diagnosis. Sorry, I'm having a medication side effect. My mouth is dry. Um, the medications that cause the biggest problem with falls, understandably, uh, anything that affects your circulatory system, your blood pressure, angina, your heart rhythm or rate, Parkinson's disease in and of itself, and as well as some of the other neurological conditions, has uh, movement, shuffling type of potential problems. And that also causes the patient to have different types of falls. Uh, the elimination process, either the urine or your bowels, are problems. The urine, what I see with the urine output, will they'll give patients diuretics, and the diuretics cause you to run to the bathroom. And when you're running to the bathroom, that's when you fall. But also, when you go to the bathroom and you eliminate, all of a sudden you can become lightheaded. And when you stand, you have a problem. The constipation, people will sit on the toilet, bent over, trying to make the movement. And then when they've held it in, and then when they get up, they'll fall. It sounds a little bit over the top, but it happens. That's the reason the bathroom is one of the biggest reasons for falls. Um, the medicines that also can contribute to falls are medicines for allergies and cold symptoms. You all may not know this, but in Louisville, per capita, we have more allergy medicine sold per capita than any other place in this country. And I'm going to stretch this a little bit and say probably allergies are pervasive throughout the state of Kentucky. Medicines used to treat anxiety, depression, and pain. They alter the brain in a lot of ways, and that can contribute to falls. The same thing with the sleep and insomnia and alcohol. My little glasses that I brought up, people think of that as being social, and it's not. Is there a question? I thought I heard background noise. Okay. The blood pressure medications, if you have a medication that says may affect blood pressure, we need to be careful with it. Our blood pressure may be controlled, generally speaking, but we have the orthostatic hypotension when we're rising and we get lightheaded. We have medications that cause the dizziness and the weakness, the imbalance, and the lack of coordination, lack of reactions, the involuntary muscle movement. Uh, if we don't have enough blood sugar, we don't function well. If we have weight loss, lots of times our weight is from our muscles, and when we don't have the muscles, we don't have the strength to get up, and that is part of the problems. They cause the drowsiness, the confusion. I could go through this. You all can read this, but one of the biggest challenges I have are the medicines or that I see in patients when they have an altered heart rate. It causes them it pause, and when they pause, that sometimes they're focusing on that and not on their walking. The gastric ulcers or the acid in their stomach can cause the dissolution of the medicine to be different. I know some medicines are you get higher blood levels when you take it on an empty stomach or a full stomach, one way or the other. Different medicines work different ways. That can give you a higher loading dose or a more minimal. So it's very important to know appropriately how to take your medicine and when. And what we in the healthcare industry, when we provide care to our patients, we don't give patients the right kinds of medicines, right kind of advice to use their medicines in the best possible way. One of the things we say this, I've given you a new medicine, take it as ordered, see me again in 3 months, 6 months, 12 months, whatever the routine is. Do you have any questions? Let me respectfully say that I would not expect a patient to have questions about their medicines, um, either at the prescriber's office or in the pharmacy, until they've read the medication guide. And the medication guide is the overview of the medicine that is required to be dispensed, that is required to be given to a patient when it is initially dispensed, and I'll get into that in a minute. But what happens in the realities of today, the seniors, our patients, their caregivers do not read the after appointment summary that the healthcare provider provides them at the end of the appointment. They don't read that. They go to the pharmacy to pick up their medicine and they're asked, did they have any questions? And they say no because they haven't read anything. They go home, and I have cared for patients in my years who have never read a prescription label. I have some who never read the medication guide. I have individuals who just take medicines. They remember that the doctor says 3 times a day or once a day or whatever, and that's how they take it. Some of them don't know what the medicine that they're using is for and why they use it, and they don't have an idea of what kind of side effects to look for. And if we're going to make their healthcare better and their healthcare experience better with us and throughout their community, we need to change how we care for our seniors, but we also need to have an expectation for them that they need to be engaged. I had a patient who took medication that was dispensed to another patient for a whole month and never saw that it was on another person's name was on the prescription vial. The only thing that saved that individual was that it was half of the dose that had been prescribed for him. I had another individual who suffered for 4 years with a problem. He went to every healthcare provider, every prescriber that he had seen, and talked to them about his problem and the medicine he was using, and no one had any advice for him. He never spoke to the pharmacy. He came to my class, and afterwards we had our appointment. He and his wife both came in crying, telling me that I had solved their problem. And I'm thinking I didn't do anything except ask him to read the medication guide. And in the medication guide, the condition that he was addressing was listed as a rare but actionable side effect. 4 years of healthcare in the millions that he expended trying to address this side effect. So what we need to do is we need to change how our seniors advocate for themselves and what they do for themselves. And this is what our paradigm needs to be. This is the message that we need to take to all patients. We need to do it ourselves in dealing with ourselves, by our family, people. We need to encourage our employees to do the same thing. Everybody should be on the same page. After you read the medication guide, the information about your medicine, if you have any questions, ask one of us on your healthcare team. You need to take the medicine as it is ordered on the label, but if you can't, go through these steps. You need to let them know if you can't take it, if you have side effects that are long-term or uncontrollable, that are problematic for you. Do not wait until the next visit. Don't wait until the 3 months or the 6 months, because if they do, many times they will forget that it's is caused by the medicine that was ordered. They get used to that medicine, but they're still off a little bit. They'll go in and they will get another medication. They have a pill for every ill. That's one of my biggest comments in my classes. And sometimes we need to think, is it the medicine that a patient's taking? When I have patients, not just patients, friends, when people come up to me and start telling me, I've got this, I've got that, or whatever, and the first thing I'll ask them, have you started a new medicine? No. My next question is, have you changed in any way the medicines that you're currently on? And sometimes it is, sometimes it's not. But my adage is, until I know otherwise, every symptom in a patient is considered to be a drug side effect until I prove otherwise. I did this for my nursing home patients in the 70s. I've continued to do it through all my patients that I was taking care of then and the ones I'm taking care of now. If there's a problem, I want to make sure that the problem that they're going to address and continually see the healthcare providers, I'm going to make sure that it's not medicines that's contributing to it. If I have a patient that is taking a medicine that has fall prevention or any other kind of poor outcome, my patients are going to know that. This is an example. When you have a fall, many times you will have a traumatic brain injury, and they're highly significant. And these are the things that are often seen with a traumatic brain injury: the headache, lightheadedness, dizziness, your eyes being blurred or tired, changes in your sleep. All of those are seen after you've hit your head. These are also some of the same issues you'll see with medication-related problems. My point is, don't always don't always think that it's the condition that the patient has. We need to think sometimes it is a condition the condition is worsened by the medicine that's being used by that patient. Um, we just need to be open ourselves as to the potential that what we're doing for a patient may not always be in their best interest, but they need to work with us, and we need to make sure we change that paradigm and the interaction. It's a double-edged sword. I think that medications are it's the most important thing that we have. We just need to use it correctly. Um, we can have multiple side effects, many medication-related problems other than falls, but medication-related problems, falls are the biggest in the over 65 population. It's going to everything that we put in our mouth, everything that we consume, medication, food, supplements, whatever, they all have potential side effects. They all have potential risk, maybe not in of themselves, but how they interact with other medicine. It's like mixing up. If we're going to fix a cake from scratch, we can have the same ingredients, but the sequence with which we put them in and the quantity will give us a different cake. We put them in different ovens, and they will bake a different way. I like to use this analogy with my patients. You're using a whole lot of different medicines. If you take them a different way, you're going to have a different response. But more importantly, how you particularly use that, how your oven is going to cook your cake. And I know they enjoy the laugh. How they handle their cake ingredients is going to give them their outcome. And people sometimes understand medication-related problems if we talk to them about food, because they understand the variances in food. Make sure that, as I mentioned earlier, that a patient brings the listing of all the medicines in use to all of the healthcare providers. They shall not assume that all the healthcare providers have it. They go through that routine, and they need to make sure that any type of information that is added, medication is added to that list. Some patients can bring the medications that they use, but when they do that, they're bringing in bagfuls of medicine. And I understand that, but those bagfuls of medicine may be a nice way to get that patient, that senior particularly, ready for the emergency if all their medicines are in one place. So sometimes it has a benefit. Um, and then all of us as healthcare providers, we need to provide an ongoing list. Pharmacists will print out a list of medicines that's used in the last year. And in reality, that's good. But what may have happened is a patient may have a medicine that's used as needed that they got 3 years ago that they're holding on to that they will use as they needed. So we need to make sure that the as needed medications are current and up to date. Now, the previous presenter talked about emergency preparedness, and what I encourage my patients to do is 2 times a year to prepare for emergencies in the spring and in the fall, preparing for winter. I I ask them to look at that ICE list to make sure that it's up to date as much as possible, or not as much as possible to all extents, not only with the prescriptions, but other things that may have been added as to equipment and devices they may need, status of healthcare, that type of thing. But to do that twice a year, and that is my twice a year drill for my patients, so they will be ready for their emergency that I hope we never have. But if we do not prepare for it, it's going to be even more of an emergency. Again, I'm going to go over the fact that my general recommendations for patients is to start low, go slow. I also ask that, eventually we get to a point where we can assure that what we're trying to treat is controlled, but that may be a little tricky as time goes on with a patient's response, but we need to manage that. We need to have a constant evaluation of each patient's response. We do that in nursing homes and hospitals. At home, we don't. So I ask my patients, you know, give me a diary about how you're feeling. Maybe you get a little calendar and tell me if your blood pressure is good or if you've had a fall or a near fall. Put it on your calendar. Bring the calendar to our appointments. It helps. We need to go slow, start low and go slow. But one of the other things I try to talk with my patients about is to try to have their health, to start new medicines when they know their medication prescriber, their healthcare provider that prescribed the medicine is going to be available for them the next day. Now, what that means is some patients might not want to take the medicine on the weekends, but if it's for a very significant medicine, I will say yes. But if it's a new medicine that's let's try this, you might want to ask the doctor, can I start this Monday when you're in the office so I can follow up with you the next day? Kind of give an expectation to the prescriber. The other issue that we have in the marketplace now is that a lot of pharmacies are closing more so on the weekends because of available staff. And if you see a physician on Friday or a prescriber on Friday, you may not be able to get the medicine on Friday, so you may be starting on Monday anyway. But the patients and their caregivers should ask if they can start the medicine when the prescriber is available. So if there is a problem, you will be addressing your problems with the prescriber that knows you or knows you better than maybe the emergency room. What I'm trying to do is keep everybody out of the emergency room. In Kentucky, the reason I think medication-related problems are so bad is our basic health in Kentucky puts us at polypharmacy at age 65. We have what was referred to years ago as the Kentucky Uglies, elevated blood glucose, blood pressure, and lipids. They each required at least one medication, sometimes a myriad of medications. So when you have that, and you have an aspirin that is often prescribed for people, or you have a vitamin or mineral, something, pretty soon it doesn't take a stretch for us to have 5 medications. And when you have 5 medications, there's a 50% potential for medication-related problems. If you have 8, that's 100% potential for some kind of issue. It may not be falls, but some kind of issue with those medicines. Again, when I say medications, I'm talking prescription, non-prescription, over-the-counter supplements, nutraceuticals, whatever. So we are at a situation in our state where we need to really manage the medicines. We need to know what the um, the goal of therapy is. I can't tell you the number of patients that I ask if they're taking their blood pressure at home. Many of them are not, some of them are. And I said, what is your target blood pressure? They don't know. They don't know what their blood pressure should be. Patients go to the pharmacy and check their blood pressure. They have other places they can go and check their blood pressure. They have home devices. I ask my patients to take their home devices and compare uh, to what the doctor has in their office. So if the prescriber gives them blood pressure medicine based on the blood pressure, when they go back, the prescriber is going to check the blood pressure. I ask them to take their blood pressure out and compare their readings according to what the doctor has, so they know how to report it. If your blood pressure device is reading low, that you know how to report it to the doctor, or you can tell the doctor, but mine's a couple points lower than what we got in your office. It's just a safety check. But the thing about it is, we need to make sure that we know here in the state of Kentucky, when you have 5 things on that medication um, listing, you've got polypharmacy, you've got the potential for medication-related problems, changes in blood pressure, fall preventions are the number one um, with medications, and we could assume polypharmacy from the beginning of treatment. A lot of people in our state are treated for those conditions well before 65. They may not have as much problem, but as that patient migrates through the age spectrum, those same medications, as I said, may be more problematic for them. It's sometimes overlooked as a symptom because it's confused with a symptom of normal aging and other diseases. Sometimes it's just resulting in even more medications being prescribed. I have seen, if you look through the chronological dispensing of patients, you can see that. You can see where a medication is prescribed and 3 or 4 months later something else is prescribed, and you know the side effect of the first medicine probably contributed, in fact, to some of the issues why that second medicine was prescribed. So, um, as I said, these are just some of the issues again and again and again of the problems that we have with the medications. And these are all the problems that we deal with when we're taking care of our seniors. So we just need to be really comfortable with the medicines that are used. I've got some notes I want to go through, but I just want to, this is a gentleman that 1493 he was born, but he was the mid 1500s. He came up with a quote, and it says that there's nothing that we have on this earth that we consume that isn't a poison, that everything that we consume has some type of poison or challenge to our system, even water. We can become overhydrated and it can be a problem to us. So we need to think that everything that we put into our system can be problematic for us, and it's incumbent upon us, both as patients ourselves, but individuals contributing to the health and welfare of other individuals, that what we are giving them has a potential of being harmful for them, not just good for them, harmful for them, but we need to balance the good, the bad, and what we call the ugly. So, if there are questions, I'll be glad. I don't know where I am, Roy. How much time do I have?
Lynn, we got a couple of questions here.
Okay, please do.
Dana asked, does Medicare still cover an annual medication review by a pharmacist? And also, what about Medicaid?
Okay. Medicaid I'm not of the understanding that Medicaid does. Um, Medicare, they're getting ready for the new update and annual review. It changes every year. So I haven't seen what's going on for 2026 as yet. I do know that there are, in some instances, medication reviews for patients under Medicare if they have a number of medical conditions or they're using certain specific individual medicines or they have a certain number of medicines. All that is generally, it varies plan to plan to some extent. So, one of the best things that individuals can do is get the patient's Medicare card that they have for their prescriptions. And there's a member service number on the back. They can call, provide the member's number specifically, and find out what is specific to that individual. And that is another problem, Roy. Everybody's different, and some people hear that their neighbor doesn't get it, and they won't try for themselves. It goes both ways. But I tell everybody, call those numbers on the back, find out what your benefits are, because
Mhm.
you are paying for it or the system's paying for it. If it's there, get it and use it and work with that. But they're making changes to it all the time. Does
Okay.
it, is that answer okay?
I think so.
Oh,
Yeah.
okay. It is not an answer. I don't know.
Right. Well, none of us know until they let us know what's going
Mhm.
to happen in 2026. So,
Yeah.
Well, the system is a lot like us. We're all individuals, and each person, that's another complicating factor in the individual's healthcare is what they elect, the program, the healthcare they elect, and the drug program they elect. It
okay.
all varies.
Okay. We had another question. This was from Ashley.
Uh-huh.
I think you've covered part of it. She was saying, when you say all medications, does this include vitamin supplements? We know that vitamin D, B12, and calcium can affect fall risk,
Hmm.
and some may counteract prescription medications. Then she asked, is this the normal part of medication review for pharmacists?
Generally speaking, a lot of pharmacists don't include the over-the-counter items because they don't have them. Um, that information hasn't been shared with them. So that's not always covered. But if you give it to whoever's filling the majority of your medicines, um, that should be something that's required to be covered. If you are eligible for a medication review, that should be something that you share and say, I'm eligible for a review. I'm taking these supplements that I realize can interfere or impact my other care. I want them included. And
Okay.
the other thing they need to say is that's part of my medical record at my prescriber's office. I need this included.
I know my doctor keeps a record of all those as well. I mean, when I go in,
Mm-hmm.
they look at all the supplements I'm taking as well.
Mm-hmm.
Then Dana asked, "What is?" And I hope I pronounce this correctly. Nutraceutical.
Yeah, yeah. They're natural products. Um, they're natural compounds. Uh, well, you'd have like vitamin C is could be considered a kind of a nutraceuticals. I guess you need to finish the question. I'm sorry.
No, that was the question.
Oh, okay. Yeah.
Dana just asked, "What is nutraceutical?"
Okay. The thing that I also want included in the medication review is alcohol. And I'm also asking for recreational drugs. Um, because what I have found is some of the patients are trying to feel good by, doing different CBD compounds and different things like that. And so that should be a part of it. A lot of patients are hesitant to tell the doctors that they're drinking any kind of alcohol or consuming any type of alcohol or using any of the CBD products. And that is absolutely imperative that everybody know. Okay.
Okay. Dana followed up. She said, I'd never heard of the term before. Just natural supplements is what she thinks you're
Yes.
talking. Yeah. Okay.
That's how I use it. And that's how I've always had it referenced to me or my understanding.
Okay. Thank you.
Mm-hmm.
That was all the questions we had in the chat.
Mm-hmm. Uh, in the um, in the nursing home environment, they've required medication reviews. They started in skilled for a number of years, and they found it to be so proactive that they required it for the intermediate care, and in some states, they do for personal care as well. And the big takeaway for me was in the 70s when I was doing it, um, patients were being admitted to us from their home or from the hospital. And I was finding at the time of admission, I was finding a large number of medication related problems and had to straighten them out, um, or address them with the doctor or make sure the nurses were using them correctly, that type of thing. And what I was able to do being on site in that clinic, I was able to stop what is called the medication or the readmission, the bounce back issue that we have for hospitals. And a lot of environments are being more aggressive about the healthcare post hospitalization, so patients don't bounce back to the hospital, but in some environments, not. The patients being admitted from the home going into a nursing facility or clinic type environment, they will come in with a medication list, an extensive medication list, and those they are given an order of admission, continue home meds. And at home, the patients on their own accord may not have been taking everything on the list or in the way it was prescribed on the list. And it's amazing because that's one of the biggest contributors to falls inside facilities is because they're being over medicated. They're giving the medicine as it's understood to have been used, but it isn't the same. So we need to be careful with that as well and making sure that um, they're the information that we get isn't always going to be accurate in caring for the patient. So we need to encourage the patient to be a little bit more, I don't want to say honest, but more realistic about how they respond to medicine and open about um, the medication not working. And
Lynn,
yes,
had a follow-up on the one of the questions.
uh-huh.
Ashley said, Lynn, thank you for the presentation. Are you familiar with or have you used pharmacy care steady RX by the CDC in your practice, or is this common among pharmacists? And just for everybody's, if you look in your chat, there is a link there. You can go and look at that if you're interested in it.
That you're talking about the steady fall prevention program.
Well, this is steady RX. I think that's, if I'm not, if I'm I haven't been as familiar with it as I used to be, but I think that's something relatively new for
Mm.
CDC. And I
I
think
have
it's
I haven't used that as yet. I have my program that I put together. It's 40 years in the making, and I'm kind
okay.
of comfortable with it. Doesn't mean I have all the answers or anything, but I'll look that up. But I have used a huge number of resources from both Steady and from NOAA in regards to information and different things that can be done for the patients. And I know that the fall prevention checklist in service that they have is really good. And I've provided that at a lot of senior centers and churches for individuals. but I am not familiar, in all honesty, of SETI RX, and I'm glad that she mentioned that so I can learn something as well.
Okay. And like I said, the link is in the chat if you want to
Okay,
look
I
it up.
will.
So, okay.
Okay.
Lynn, I think we all learned a lot from you. You gave us all something to think about with your presentation. You covered so many areas in depth. It's just really helpful information, just not individually, but for those older people. Like I work with my 90-year-old mother and her medications. I have power of attorney, medical, and so on.
Mhm.
And you're on target about the importance of reading those labels. I
Well,
cannot be stressed enough.
what happens is we get our appointment, we make an appointment, and we have to wait sometimes months for that. And then, we have to get to the place. It takes a little
Mhm.
bit of time for that. It takes us time to get from the car to the doctor's appointment. We wait for it to be called back. And then when we get called back, we go through the intake with the staff, and then we wait for the doctor. And then we have to wait for the lab test. And then all of a sudden, the healthcare provider writes a prescription for us, and we just take it. We don't wait to make sure that we know what we're doing. And we're assuming all that stuff is fine, and it may be, but still we need to baby ourselves and not put anything in our mouth that we don't know what it is. But
Mhm.
we do it every day, day in and day out.
I want to thank you on behalf of everybody for this wonderful presentation.
Well, thank you, sir.